So, good morning, or indeed good afternoon, ladies and gentlemen. Welcome to the latest in our series of COVID webinars on for health professionals and by health professionals. Now, there's been a lot of talk this week of COVID cover-ups, possibly in China, or maybe here, or by President Trump and all those things. But cover-ups and conspiracies, as we know, are rarely true. But there's one cover-up, which is what we're going to discuss today. That is the cover-up as whether or not we should or should not cover up our faces. Now, my guest today is Professor Trisha Greenhalgh, Chair of Primary Care at Oxford, Primary Care Health Sciences, and I have to say, an old friend of mine from a long way back. Now, Trish can write on everything. She's written recently on technology, systems, health-related behaviors, complexity consultations, tips for Twitter users, asthma, why we wonder, and what really goes on in a Skype conversation. And that's just the last 24 months. But it's her latest BMJ article that has, as ever, got the headlines and we'll be discussing. But before I do that, Trish, I've had quite a few people asking from your Twitter. First of all, they want to know, how's your son?
Oh, that sounds absolutely fine. Yeah. I did post a tweet about my junior doctor's son who came all the way home from his gap year to work on the COVID wards, and he quite quickly got COVID, but he recovered in about a week and is now back at work. He's doing a night shift at the moment. I mean, not night. I guess he's asleep. I don't know. Okay,
he's obviously a chip off the old block, and we all
very much so.
We all wish him well. So then, you had your latest BMJ piece in which you make, in your usual compelling and convincing case, the case that it's time now that the public should be adopting face masks. Take us through the argument, shall we? Shall we take it from the top and take us through your reasoning?
Yeah, so that paper, I can't remember the exact title, but it included the words precautionary principle.
It did.
And the whole point about the precautionary principle is we only need to invoke it when we're not 100% sure about the evidence. So first of all, to those who say, the evidence is equivocal, I'd say, well, to some extent it is. We'd like to have more rock solid evidence than we've got. So the paper was arguing that, look, we've got an awful lot to lose if we get this wrong, and we don't really have much to lose if we start to ask the public to wear face coverings just in case. And so it was about the balance between potential benefits and potential harms, given that the evidence is uncertain.
All right, well, let's take you through that in a little bit more detail on that one. And remember, as I say, we go a long way, and I remember you being a tremendous champion of evidence-based medicine, and I know you still are. And some of your colleagues are not quite so convinced, or at least seem to be not quite on the same side. From your own unit, Carl Hennigan and Tom Jefferson, who we know, they basically say, there are 14 trials that they found recently, and the evidence is, quote, disappointing, showed no effect in either healthcare workers or in community settings. Now, if something really is ineffective, neither you nor I would be proposing it. Why waste our time or money? So how have we got this disparity in views?
Yeah, so I think COVID-19, I think, could be evidence-based medicine's nemesis. And I think it's really important to not to bandy about the term evidence-based unless we clarify what we mean. Now, if you take a narrow view of evidence-based medicine, EBM, you have that pyramid. Do you remember that triangle with the randomized controlled trial or the meta-analysis at the top? And then right down at the bottom, you have anecdote. Now, if we take that view of evidence-based medicine, then what we really need is a large randomized controlled trial, preferably a meta-analysis with all the evidence, experimental evidence, stacking up and giving us a definitive answer that we've done this big experiment. I would say we need to put aside the traditional hierarchy of evidence, because I don't think we need to hang our hats on big randomized controlled trials. And as you say, Simon, I'm passionate advocate of EBM. I'm a cancer survivor. I owe my life to a randomized controlled trial. I totally understand that methodologically they are extremely high quality for testing drugs. Now, what we've got here is a complex system. I think everybody realizes that the knock-on effects of one aspect of the COVID crisis are often quite unexpected. And, you know, that's why we've all got our kids running around the home because the schools ended up being closed, all sorts of things. You know, oil now, suddenly they're paying you to take the barrels of oil away. The price of oil is now a minus number. Did we anticipate that? So what we've got here is a complex system with all sorts of effects firing off all over the place. And that is not really the kind of setting where you can do a controlled experiment. Now, there have been RCTs of mask wearing, and they've come up with different answers. The methodology of those studies has been questioned. Some of the studies, for example, have been in university halls of residence, where some halls of residence have been told to wear masks and some haven't. And guess what? Half the students didn't wear the masks that they were supposed to wear. That's no surprise. But does that mean that you and I wouldn't wear a face covering in the current pandemic, given the huge implications of this pandemic for getting on with our lives and also for our own, actually ours and our relatives' lives? So I think it's all very, very complex. So the kinds of evidence that you need in a complex system are not necessarily statistically significant effect sizes that you would see in an RCT. So you might, for example, stack up a bit of evidence from laboratory science, a bit of evidence from mathematical modeling, a bit of evidence from materials science, you know, firing things at and through different kinds of fabrics. And if you point all that evidence, if you put it all together, most of it points in the direction that face coverings for the public will have some effect. And of course, we're talking about what we call the effective R0. In other words, the number of people that each individual with COVID might infect. And we've got to get the effective R0 below 1, which means that we've got to reduce the amount of virus circulating in droplets, particularly on places like the tube or in supermarkets where there's an awful lot of people breathing and coughing.
Trish, so getting a lot of practical questions, but I just want to push you just a little bit further though. Okay, so you're disregarding the RCT. So what is but there's got to be something there. You haven't just, you know, you're not Mystic Meg, you haven't just made this up. What do you think then is the important evidence that has made you come to the position that you have? What is it that we should be looking at if we need convincing?
Well, one of them is, it's a very straightforward thing about, I don't know if you had a look at those videos of people coughing and sneezing.
I'm not quite
sure how they do it, but you know, you see someone coughing and right close to their mouth, there's a huge amount of gob and drops. And you know that because if you cough on your hand, your hand gets wet. Now, what happens to those droplets quite soon after they leave your mouth, within a couple of inches, they kind of, I don't know what the technical term is, it's probably not vaporized, but anyway, they're not droplets anymore. So the best way to stop droplets is at the source. In other words, very close to the mouth of the person who's doing the coughing. And that is a highly effective. There's no doubt that laboratory experiments have shown that if you put a cloth in front of your mouth, you stop the droplets coming out. There's one experiment where someone measured 8 inches away from a coughing person, which is closer than I would get to most people, apart from my own husband. And what they found was that 2 layers of cloth reduces the amount of droplet hitting that other person by 36 times. So you're only getting 1/36 as many droplets 8 inches away if you simply use a folded over piece of cotton. Now, that may not be enough to protect the wearer, if we're using medical grade, but it's certainly enough to dramatically reduce the droplets that are circulating, for example, on a tube train.
Now, Nick Francis has asked, which is this, that that's all very well, I'm paraphrasing slightly, but first of all, the key thing here is the distance, right? It's the distance we have. And so long as you are keeping to the guidelines on 2 meters away, you won't be affected by that anyway. What about the risk that by wearing a mask, you give us a false, and the mask is of course not to protect you, it's to protect others, that you're giving us a false sense of security, and people may be, it's like the argument on cycle helmets, people may actually come closer to you, or you may come closer, which is definitely a bad idea because you're wearing a mask.
Right, we've got an awful lot of countries now who have introduced mask wearing I have not yet seen any scientific evidence whatsoever to support this straw man argument that if we wore face coverings, we would then behave irresponsibly in other ways. We would suddenly stop washing our hands. We'd go around, you know, hugging people and getting really close to people. The plain fact is that when you're sitting on the tube, you simply cannot be 2 meters away from the person sitting next to you. It's not possible to socially distance in things like also supermarket queues. It's simply not possible to do that.
I think people disagree on that. Certainly in London it is. But anyway, but I take your point. I take your point. But I think people are socially distancing in supermarkets and on public transport, such as it is. But the point is that the next contrary question on this is that, of course, one of the advantages of face masks is it kind of stops you touching your face, and we know that the main transmission of the virus comes from touching, doesn't it? You pick it up on surfaces and then you lift your arms and you touch exposed parts, and that's the major transmission route. But what happens if actually with the face mask, you end up touching your face more? If you're taking it off, you're on, all the kind of things, you don't use it as you should.
Well, where's the evidence that wearing the mask is actually increasing your contagion? I mean, people speculatively say that. But if these people are calling for evidence, I want them to provide some. You know, actually, when you've got a comfortable face covering on, you make it out of an old t-shirt, it's nice and soft. You're actually going to be touching your mouth and nose less than if you weren't wearing the t-shirt. Okay.
And then another question we have from Dr. Cho, who's a deaf doctor. And she says that if people are wearing face masks, she basically can't do her job. She says she just can't. She doesn't know what you're saying. The only way then would be to put her ears right next to your lips, or so close that it would be ridiculous. So she says face masks will actually put her out of the job or make her unable to work.
Yeah, so I acknowledge that people who are hard of hearing and deaf, there is a real problem there. I didn't make COVID. I didn't create this problem. I was on Twitter last night and somebody who was deaf responded to my call for face coverings. And they said, I've been deaf for 10 years and I made the mistake, I now know, of choosing to learn to lip read rather than learning British Sign Language. And I won't be able to lip read. However, it's a price that I feel is worth paying. So the question is, yes, sure, this is terrible for people who are deaf and who rely on lip reading. On the other hand, hopefully it won't be for very long. And if it gets COVID under control, that may be a price worth paying. The other thing to say is that I saw a pattern on the internet recently for a face mask with a little plastic window where you can actually reveal your lips. And those, of course, we're not all going to get round to wearing those, but certainly if you know that you're going to be interacting with people who are lip readers, it's perfectly possible to make yourself a mask where your lips can be visible.
Okay. Now, Julian Huppert, who must be the ex-MP, he was my MP for a while, and is also a distinguished scientist, he said there are no disbenefits from encouraging mask wearing, so surely you can't just invoke the precautionary principle in one direction. I think that's aimed at me more than at you, actually. But let's say then that we do start to encourage them. But the point, that's a slightly convoluted question here, but my point is this. It's been available to people to wear face masks from the start of this epidemic. It's been perfectly possible, and people do. And we know that there have been huge population changes in hand washing, hand shaking, distance, social distancing, travel, etc. All of these have taken place without the government telling us to, by the way. That's almost been the icing on the cake. But why hasn't there been a major shift? Because it's still pretty uncommon to see people with face masks. They've had weeks now to do this. There seems to be more of a cultural reluctance in the UK and some other countries. And do you think that we should just leave people, you've given your advice, lots of people have, we should just leave people to it and they can make up their own mind on this one because it is uncertain? Or do you think we're going to have to make them compulsory?
I would say that I think the reason why people are not wearing face coverings, or many people are not, is they're getting mixed messages. You know, different people are saying, you know, the evidence is there, the evidence is not there. So I'm not surprised. I wouldn't blame anyone at the moment for not taking action. I think Sadiq Khan's done his homework, and maybe the reason why Sadiq is ahead of the curve in terms of politicians stepping forward is that he does have this challenge of particularly commuters on tube trains, where, you know, you could actually almost follow the patterns of COVID in London along the tube lines. So I think once you get a clear message, I suspect more and more people are going to be taking this up. I'm not sure about this cultural thing. I mean, I think 2 or 3 months ago, you could say that it was a cultural thing in Asia or some Asian countries to wear face coverings, and it wasn't here. But I think things are changing very rapidly. I mean, I live in Oxford, and it's very common now to see people wearing face coverings when they're walking their dogs and things like that.
I'm not saying it's not happening, but the handshake has disappeared, but covering up has not, you know, taken its place as in terms of nearly perfect population compliance.
Yeah, that's true. But then the handshake, you know, the social distancing, you know, we're about 6 weeks behind. So let's see what's happening. Bring it back in 6 weeks' time. And I rather suspect, you know.
Yeah, the point I'm making, in Japan, before all this happened, you know, in the last, I could find figures for 2018, 3.5 billion face masks were imported during that year. So, you know, for them, it's become the norm for not just hygiene reasons, but it doesn't seem to have done yet. So you're basically, as I understand it, saying then that we should be advocating this, but you stop short of saying it should be compulsory.
Yeah, it's a difficult one, isn't it? Because I'm not the kind of person that wants the government knocking on my door, you know, as if they're issuing gas masks or something like that and telling me I've got to wear it. I would much prefer this to be a voluntary thing for, you know, 80–90% of the population saying, yeah, I've got no particular reason why I shouldn't wear one of these. I'm happy to kind of, you know, stack the odds and all that kind of thing. There might be some people who feel so strongly about civil liberties, or they've got a particular reason, they've got a facial allergy or whatever, that they don't want to wear one. Or indeed, you know, children under 2 should not be wearing face coverings. Yeah. That's CDC advice. But actually, if 80–90% of us do it, that would, the modelers say, be enough to reduce the effect of R0 down to wipe out this disease and not get on with our lives.
You made that point well. Jonathan Flaxman here, getting a high standard of people, I must admit, says we need to trust the public to be sensible about this and follow clear advice. I do worry a little bit more, though, about those who don't will find themselves quite stigmatized, and we're already seeing that happening. We're seeing spontaneous, almost vigilantism in the population. Those who choose not to do that may find life increasingly difficult.
I think that's probably true, but maybe finding life a bit difficult is better than being dead.
Okay. Okay. Now then, let's go into more practical things then. So now your lad was ill, my wife was ill, and when she was ill, she had with the COVID, she had a face mask was given to her. I wasn't. So this is what I used. Okay, this is my form of is
this where the Chelsea scarf comes out? Oh dear, oh dear. Okay, now, right.
But somebody did say on Twitter, if that doesn't cause social distancing, nothing will. But let's go to what the public can do. Now, we know, everyone knows that we're not advocating using the medical masks. There aren't enough to go around. And so we're talking about a lot of this is going to be DIY masks. So, and you've been writing quite entertainingly on this, I think. So tell us then, what are the kind of things we should be doing then if we don't have access to, you know, NHS-style masks?
Well, first of all, and I mean, I know this is a medical audience, but even so, you know, I'm a medic, but I'm not currently patient-facing, and many doctors, you know, I hope all doctors have lives outside the hospital or the clinic. So we're talking about when you are operating as a citizen, as a member of the lay public, you do not need to wear a medical grade mask, and nobody, for example, in a shopping queue or on a bus needs to be wearing a medical grade mask, because that's not the way they work. They are intended to protect the wearer. Now, how do you make your own mask? You take 2 pieces of cotton or a piece of cotton folded over, and you take a panty liner or something like that, and a little bit of kind of waterproof backing. You stick it between those. and then you hook it around the back of your ears. I've heard the best thing to do actually is use a pair of old tights. Every woman's got a bag of old tights that they're never going to wear, and actually, if you haven't got enough elastic, the tights are much softer behind your ears, apparently. So that's the way to do it.
Someone, I mean, this has to be the UK. Someone asked about, what's your opinion on artisanal masks? I'm not quite sure what artisanal. I don't know. I think this is the idea of masks as a fashion accessory.
Yeah, well, funnily enough, I've got a little back channel going on Twitter with a jazz singer called Kitty LaRue, who's become a bit of a poster girl for masks, and she's sending me all sorts of fashion labels saying, look, do you think we should talk to this fashion house and get them making fancy masks? I'm not sure about that. I'm not a great fashionista myself, but if it helps, then that's great. I do know that one very small clothing company turned to making face masks, face coverings, and were slagged off by allegedly by an NHS nurse, although I suspect this may have been planted because it was an anonymous nurse who said, I think it's disgusting that they're profiteering from this. Actually, they were only £5, I mean, yeah, sure, buy a mask.
Okay. I must admit, the questions are quite divided, actually. There's quite a few people who are worried that this marginal judgment will suddenly become the new norm, even when this is over, that this is what we'll do. And others are saying there are psychological effects, that people don't like it, can't see people's facial expressions. We can't just say this is completely without side effects. But there are plenty of others who are.
I don't like it either. I would way prefer. Was I getting on the telly talking about wearing masks before COVID started? No, I wasn't.
No.
It's fine if if it's a religious thing. But
I think
come on, have those people been on an intensive care unit recently? We're doctors. This is a terrible, terrible disease. And anything we can do to stamp it out is a good thing as far as I'm concerned.
Okay, all right. So as I say, there's a lot of people who are also agreeing with that, but more are worried about the compulsive aspect. And the last question, this is this morning, Chris Hobson, Chief Executive of NHS Providers, he is still worried. He says there should be clear evidence securing supplies to the NHS staff amidst the huge global demand is still crucial. So he's not in favour of this because he still thinks it will, as a procurement way, we should be concentrating on the NHS and where are we going to get the 5 billion masks?
Yeah, listen to what I've been saying. I'm not saying take medical masks and give them to the public. In fact,
he's saying the procurement issue would detract from that procurement issue. It would introduce another demand into the system.
Making your own masks,
if you make your own
sewing machine out, isn't interfering with that.
Okay.
I don't get the logic there.
All right. Now, at the same time, as I said, you are the ultimate polymath and Renaissance woman, which you are, and you've done huge amounts of work on primary care systems and organisations. We haven't had a GP on this series before, something my wife has been going on about quite a lot. But tell us then, because we were talking earlier about, first of all, how GPs, are, because a huge burden is being put on them, which has not really been talked about very much, but about the transformations happening in primary care and how GPs are keeping the system going.
Well, 90% of COVID is managed in primary care, and I'm not working at the front line, but I have been working to support the very rapid changes at pace and scale. Change at pace and scale is the slogan we're using to shift general practice in particular from the sort of street corner family doctor where people walk in, make an appointment, all that kind of thing, to a service that is run almost entirely virtually. And I heard a statistic the other day, 93% of GP patient consultations are now done either by phone or video. Only 7% are face-to-face. This is an absolutely massive change in the way people interact with their family doctor, and also with the way the family doctor is linking with the hospital service, the pre-hospital service like the ambulance, and also these new parts of the service that are springing up like the hot hubs and the virtual wards. So it's not just a change in technology, you know, phone or video, but it's also a change in workflows and in patterns of interacting with other professionals and also, of course, with patients.
Okay, and the transformation has been quite remarkable, hasn't it? That face-to-face interviews are almost as antiquated as smoke signals and semaphore now.
They are, except that I would say that some, you know, not everybody suffers from COVID, and I've heard some stories from people who said, you know, I've reluctantly suggested that the patient come to the surgery to be examined, and then once they could be examined, you know, when you look in, for example, down in their ear and you see something you weren't expecting, that kind of thing. You know, we have to remember that primary care in the UK and indeed anywhere is dealing with a vast gamut of things that might be wrong with people, and some people still do need a face-to-face examination. And I read somewhere that in the COVID epidemic, one of the things that's going to kill people is non-COVID serious conditions like pulmonary emboli, myocardial infarction, sepsis. You know, everyone listening will know the list, but we have to be alert to those. And so once we've completely re-engineered the service to deal with COVID, we've got to remember, well, what are we missing out? And actually, one of my colleagues has just sent me a rapid review just before I came on. I think it will be uploaded on the Oxford website very soon. And the things that we may be missing are things like, you know, bacterial pneumonia, for example. So we, you know, we have to be on the ball for those as well.
Yeah, and also psychosis and other issues as well.
Absolutely, absolutely.
Now, tell us then, though, what role will GPs play as we try to get out of this?
Well, there's a question. I think one of the things that, I mean, we're not nearly getting out of it yet. We may have just about started to flatten the curve. Because of lockdown, there is likely to be a fall in the number of new cases, followed a couple of weeks later by a fall in the number of deaths. I think that's beginning to start happening. But of course, we come out of lockdown, and I've certainly had the emails, and many people listening will have had the emails saying you can expect another spike in about 3 weeks' time as we come out of lockdown. So I think this idea that it's all going to be over with quite soon, I'm not sure about. So to tell you what my team are doing, because I do research as well as you know, go on the radio and things like that. What we've been doing is to try and refine a COVID-specific early warning score. It's going to be called the RECAP score, remote COVID assessment in primary care. And the idea is that we're going to put in the evidence base on what predicts poor outcome in COVID, so that the GPs doing the remote assessments and also pitching people towards hot hubs and things like that are better able to discriminate between the patients who are going to do fine, like my son and your wife, or those who are going to go into that ghastly pneumonitis in week 2, where they will need oxygen therapy and hospital management. So the early warning score is something I'm working very hard on. We're hoping to get the ethics through and get that onto the GP systems before the spike in cases that we're anticipating in 3 weeks' time, so that people with serious COVID hit the hospital a bit sooner and have a greater chance of survival. After that, what a GP is going to be doing, I actually think, you know, going back to business as usual is going to be a really difficult thing, because at what point do we start scaling all this back? And to be honest, I haven't been involved in the plans for that, but I think it's probably time that we started to think about it. Maybe some people are, but I haven't heard it. You know, I'm on a lot of the email lists, and so far people haven't started talking about coming out of this.
Well, I think people are, but it's a question of when, Trish. I think we'll be running these seminars for a hell of a long time to come, to be quite frank.
Yeah.
So Trish, someone else has said, and it's not a question, they just said, I love Trish, she's a legend. Dr. Chatterjee has just said that.
Oh,
and,
thanks.
I know, there's no question at all that that is the case. I think I think from the very lots of comments that we're getting, there's not yet a clear consensus emerging, but I think many people think we should be encouraging more, but the compulsory bit seems to be, for a lot of people, still perhaps a bridge too far, and we should continue to rely on people doing this altruistically to protect others, which is always the best, rather than making things compulsory.
Yeah, I would agree with that. Yeah. I mean, I'm not sure that I would agree with it on the tube.
No, maybe not. No, fair.
But then I'm with you. I'm not a great one for compulsory things. I was quoted in the Times this morning as having said it should be compulsory, and I don't remember saying that. So yeah, just kind of put the marker down there.
Well, given the amount of things you've written on choice and how you get better outcomes with more choice, I didn't expect you to be. So then we'll have to call it a halt there. And just to remind people that next in this series, in 48 hours time, will be David Heyman. Now, he happens to be the person who's chairing the WHO committee, revisiting their face mask guidelines. And I'm sure we will come up again, although he has a lot more to say on a lot of other things as well. He's definitely the expert when it comes to pandemic. And also to remind you, before that, join me tomorrow evening, that's at 7 p.m, for our longer In Conversation, in which we step back and take a longer view. And who better to do that than a historian? And we have one of the historians, Andrew Roberts, who's just written a book on leadership in a time of crisis. And no doubt we shall go over many examples of that. So that's 7 o'clock tomorrow. So once again, thanks, Trish. Thanks to all of you for coming. And I should also say that next week we'll be having a kind of wrap-up session in which all those questions that are coming through that we've not been able to answer, we've had several hundred today, we won't be able to get through them, but we will take a selection of those questions and put them to a panel. So as I always say, see you later, but until then, do be careful out there. Thank you very much.